Gluckstein Lawyers proudly present Butter Torts, a truly Canadian legal podcast. We're excited to have you join us bi-weekly as we interview guests on a variety of different topics related to personal injury. We look forward to sharing our expertise, insights, and most importantly, our stories with our listeners while providing a better understanding of the personal injury legal landscape. You'll have a chance to meet many members of our amazing team and learn more about the role they play in helping our clients lead better lives.
Hi, everyone, and welcome back to another episode of Butter Torts, a truly Canadian legal podcast. We are going to hopefully get through this podcast with no dogs barking, no technical issues, because we are going to post this both video and audio, trying to do something a little bit different for 2025. So anyways, my name is Brenda Agnew. For those of you who are not familiar with me, if you're new to the podcast, welcome. I typically try to co-host along with other people, but sometimes I go solo. But it is my pleasure to welcome Kristy Dickinson to our podcast today. And Kristy is a good friend. Our kids are friends. We do a lot of work in the same sphere. She is a disease patient. She is a patient advocate, as evidenced by her sweatshirt. Let me see your sweatshirt, Kristy. And she wanted me to say that she's a health strategist. And I didn't think I was healthcare strategist. And I didn't think I was going to remember to put that in the intro, but I did. And also recently launched Kristy Dickinson Consulting, although you've been doing that work for a really long time, but now it's sort of official in like one package with the website and everything.
Yes. Yeah. Thank you, Brenda. So excited to be here today.
Thanks. So we are, as usual, just going to see where this conversation goes. When I was talking to Kristy, we talk a lot about the healthcare system navigation. Often we talk about what's going wrong as opposed to what's going well. And so, when we were chatting a couple of weeks ago, I said, it's not lost on me that the importance of patient voice and patient advocacy and all the things that go with that. It's not lost on me that those are important pieces that I think, were they more pronounced, were they more respected, were they more evident, we may not see as many cases sometimes in medical malpractice that we do. And I thought, let's have a conversation around that, because we both advocate really strongly for things to be better from a patient perspective in the healthcare environment.
And a caregiver perspective.
Right. Absolutely. And so, I thought, let's have a conversation about that. Let's sort of talk about, those, what we can see for quality outcomes, what we can see for reduction in patient harm and things like that, possibly if we were a little bit more, as a society, as communities, really more vested and truly respectful of patient voice. And so we thought we'd have a little conversation about that today. And maybe that resonates with some of the people that are listening to our podcast. So that's a big topic. But, we come to it from a place of lived experience.
Yeah.
And, we often see people who come to us with a misdiagnosis or a delayed diagnosis or all of those other horrible things that we hear that happen sometimes in hallway medicine or, in the ER. So tell us maybe a little bit about sort of your experience with some of those issues. I know you run into roadblocks sometimes, Kristy, and so have the people that you work alongside.
Yeah, it's timely because we had to delay the start of this podcast so I could take a call from my infusion clinic because I had to track down my own drug.
There you go.
That was, for a process that is supposed to be seamless. I was advocating for myself on Friday afternoon for 4:30 to, I get infusions every 5 weeks and they're 3 hours long. So if you think about from a patient experience perspective, if there's no drug at clinic, that I work,
right.
Carving out an entire afternoon to go sit in an infusion chair can't just be done without notice when you're really working together as respected and care, I think collaborators or care partners, but I digress. That's a topic for another time. It's just another example of the advocacy never stops, even even when you think you've got a process or a plan or a treatment that is running smoothly, something in the system happens to shake that up a bit. In terms of advocating, listen, I live with a rare disorder. So just getting to that diagnosis took almost 7 years, just over 7 years, of relentless advocacy. And was that a delayed diagnosis because, well, we don't educate healthcare providers about rare disease? It's like a paragraph in a textbook. The system wasn't built for people that don't fit into the square holes. Like if you're a round peg, the system isn't built for you. So there's going to be a delay there. I think there's just a lot of opportunities. So you and I do talk a lot about the things that are broken. Where I'm choosing to try and focus my advocacy time for 2025 is where are those opportunities and how can patients and caregivers continue to do the work to change the way that the system works, maybe looking at quality standards, or we're seeing a lot more patient-reported outcomes being used as evidence because they are, like, especially in the rare disease space. Our lived experience is what drives and propels research and innovation and commercialization of medicines. So there's a huge opportunity to use the advocacy work that we all do. I mean, your advocacy work has been used to build quality standards and to be evidence for clinical outcomes. It's there. It's just we have to look at how we operate within the system differently, I think.
Yeah. And I think a lot about, I think about, the average patient who goes into a hospital environment. And we've talked before, a hospital, I'm using that as an example, a hospital environment, but it could be, your doctor's office could be whatever that is. It could be an urgent care clinic. It could be a walk-in, it could be anything. And, the average person, and rightfully so, there's a level that, physicians and clinicians sit at because they do have years and years and years and years of, schooling and, clinical experience and all those sorts of things. And so that is not to be discounted. But, the average person that goes in, we do often hear stories about comments, concerns, questions that come from patients that are often dismissed or not taken as seriously, or for whatever reason that might be. I'm not going to start going down the rabbit hole of funding and, pressure on our healthcare system, because at the end of the day, I kind of look at it as a one-to-one. You've got a physician, you've got a doctor, you've got a patient, they're having a conversation about what might be going on. And we often will hear from patients, I hear a lot from the caregiver community, that, the discussions, the questions, the concerns are not always taken as they should be, and they can quite often be dismissed. And so I think it often falls to people like you and I and others who are in this realm, who are going down this journey to do this work, because I think we have to change things from a systemic perspective, from a system perspective, so that we change the culture, because we're not going to be able to change all those individual instances. So we have to find ways so that when the average person goes in, is expressing a concern to a physician, they're not being automatically dismissed or they're not being discounted, because we have changed the way things are approached, the way we speak with patients, the way, the way that we do that work. And that has to start way back as things are being implemented, I think. Yeah. And that's some of the work.
Medical school, really.
Right. 100%. So give me your thoughts on that, because then I want to dive into sort of the individual person. But I think it falls to sort of people like ourselves, because they'll often say, Brenda, why do you, same to you, Kristy, why we could fight our own battle individually. I'm quite loud. I get my way. It's not always easy, but I often triumph. I will say that in the end. But why is it important for people like ourselves to try to make those changes so that they are inherent and solidified for other people that are coming down the pipe, if you will?
Oh, there's a lot of reasons why it's important. The one that's on the top of my head right now is that advocates, like caregivers and patients, are filling a huge gap in our healthcare system right now. And that gap is only going to get bigger. So we know that we've got a primary care shortage, Canada-wide, but in Ontario, we're hitting, I think, close to 6 million unattached patients. So just from the start, if you're not advocating for yourself, you can't. There's going to be delays in diagnosis. There's going to be misdiagnosis. People are going to be presenting in an ER where that's not an appropriate place for you to be just to get to a specialist. Like, so, I think when we look at advocacy, it's one of those situations where oftentimes I think, like, if you think about how you and I got started, we got started from a place of need.
Right.
And so I don't know that I can speak for myself. I didn't grow up thinking, gosh, I can't wait to fight a healthcare system and to try and earn a medical degree on my own and to, consistently try and push this rock up a hill to get myself treatment and care and coordination of care and to understand how to navigate a system. There was not a program like that in university. And if there would have been, I wouldn't have gotten in because I certainly was not strong in math and science.
Right. Great. In math and science here.
Yeah, really. What I think is at least I have seen over the last decade, a shift that I believe is positive. It's small, but in healthcare, I think we have to take the small wins because we're never going to see like an implosion. Hopefully we don't see, it would be great, but a complete implosion of the system and a rebuild into what we need. So all of our wins are going to be small and incremental. I've noticed a considerable shift in healthcare providers taking a more collaborative approach to care than even a decade ago. Right. So, when you would walk into a doctor's office and see on the wall, don't mistake your Google search for my MD. Respectfully, you're right. You went to school for a real long time, and I will never discount the work that you do, but don't ever discount the lived experience that I bring.
Right.
Because what we know is that no two patients are the same, and that's where things get missed.
Right.
So just because you treat one diabetic patient doesn't mean that you fully, completely understand every diabetic patient's experience. So you have to be looking at, in my opinion, the human, and we're hearing more talk about personalized medicine, personalized care, humanizing that experience. So that's where I see some opportunities for advocates to lean into, is like when you have that time, if you can get a doctor, when you have that time. I have said, like, I've stopped appointments and said, I just need a minute because I don't think you're hearing what I'm saying.
Yeah.
Or, like, I'm coming in with this. You want to immediately, I've seen this multiple times before. I think you've got this. Well, sorry, can you just take a beat? Yeah. We know that I'm complex. We know that, what presents this way in most people. Can we just validate that assumption? And so I think it's hard because we can't change the system. I think that there's a level of burnout amongst every person in it, healthcare providers, patients, caregivers. But we, as the advocates, can't take our feet off the gas because it's literally our lives or the lives of people that we love. If the like, I say this respectfully, but if the doctor misses something, they still get to go home. At the end of the day.
Yep.
It's us that have to live with the consequences. I don't even know if I answered your question.
No, I think you did. Absolutely. And I think a lot about, people, I'll get calls from parents, or our firm will get calls from clients or, potential clients who will call and they'll say, so two things that I think lead into this conversation. One will be, is there's a lot of times where we will see the error that occurred, and it's often an error that a patient pointed out. A mom who's in labor who's, something's not jiving. Something is not feeling right. This is not, um, and we quite often have seen that dismissed. And then unfortunately we see a situation where there's been a birth injury, and now we have, a family and a child who's going to live with that moving forward. And, listen, some of these are not preventable. There are situations that happen, and there's often, there's just as many times I think where a patient says something or mom says something's not going right here, and the team jumps in and they take care of it. But there's a lot of instances where they don't. Mom is dismissed. She's a hysterical first-time mom, or she's whatever that might be, right? She's worried, blah, 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 blah. And then we end up seeing where there's a situation. And we hear that not just in labor and delivery or in obstetrical. We hear that a lot. We hear patients that come and say, I sat there in the ER, I was confident I was having a stroke. We see missed strokes all the time. And it's often because they are dismissed. The symptoms are dismissed. The person's story is dismissed. There's an assumption that the person maybe is, I don't know, something else going on. And we often see that happen. And so, then you take a look at, I often say that there's so much more cost to those medical errors than there just is to the family that's dealing with it. Because now you have created, I see the OHIP summaries I don't see them, I saw them for mine, but there are OHIP summaries that are created for some of these case settlements that they take a look at when they do the costing. And think about that. So someone's not listened to, there's an error in the care that is being given. There's a lot of instances where that patient was in fact right, and no one wanted to listen to what they had to say. No one wanted to listen to the person that was with them. They were completely dismissed. An error happens, someone is left with an injury. So now there is obviously the financial cost that person's going to bear in their recovery and their rehabilitation, whatever that might look like, lost wages, all that kind of stuff. Now there's also a drain on our healthcare system. So now there is extra cost because guess what? That person is now going to have to possibly go for rehabilitation therapy. They're going to have medical needs. They're going to be in and out of the hospital for other things that are going wrong. And, so the lawsuit is just one part of that. That's, insurance companies pay that off. But then what about the long-term effects of not listening to patient voice when you run into these kinds of errors?
Well, and I think, so you're right. I think that the journey starts long before an injury or a missed diagnosis, because it's systemic in how we've built the system, how the system is built. So I've never met a healthcare provider that does not want to heal and isn't inherently there. I mean, okay, maybe one that's not.
I got a few, but that's fine. We'll keep it positive.
But I'm going to say 99.9% of clinicians that I've interacted with, allied health professionals, nurses, they are in this job because they deeply are passionate about healing.
Yeah.
We would be remiss if we didn't look at how the system is built, because they're not set up for success from the get-go. So when you go into that ER and you are sitting there waiting and you're having a stroke, well, that, from the minute that you walked in, why are people in the ER? There's a lot of people that don't need to be there because they don't have access to healthcare. So I think that there's so many, it is a multi-layered issue. But if we zoom in and just look at how do patients interact with healthcare providers?
Yeah.
First of all, there's an inherent power imbalance. That's a problem. So God forbid, you and I are educated. English is our first language.
Yeah.
We are pretty clear communicators.
Yeah.
I advocate daily. And there have been times that I have been unable to advocate for myself, and that has resulted in harm or injury.
For sure.
So add in a barrier of language or past trauma or what have you.
Yeah.
And then add in the power differential or imbalance. So if I say, listen, it really isn't feeling right, and they're paying attention, but not, because they've got 50 other things that have to do.
Yeah.
That they're in the process of doing. I think it's so easy to see how things get missed.
I agree.
And I genuinely, like, I couldn't do this work. You and I often joke, I'm the optimist. I couldn't do the work that I do day in and day out if I didn't truly believe that everybody in this ecosystem are there for the right reasons. So if we just, I understand that I'm wrong.
Yeah.
I get it.
No, you're not wrong. No, you're not wrong. Because I also work alongside a number of clinicians who I do a lot of work with because they want to make it, they do want to make it better.
Yes.
They want to make everything better from the initial to, they want to have these conversations in med school. They want to have these, in early years with doctors. Like, they do want to do that work to change things inherently to make it better for the patient in the long run.
So I think it's the how, right? Like, if we know today that in 2025, you and I are talking, we know that our healthcare system is overburdened. We know that we've got a loss of healthcare providers. We've got inherently huge cracks in our foundation and massive gaps on an already shaky system that was already not built for the demographics of the patients that they're serving.
Yeah.
Like, the how is how we're going to change. So as an advocate, how I change is, or for myself or the people that I help or work with, would be, you need the data.
Yeah.
Like, clinicians respond to evidence and data. So I advocate for everybody to keep all your medical records, get copies of your medical records. That's your data. And when I try to have a conversation, in the moment, so like labor and delivery, that's not my, like, right. In the middle of having a baby or in the middle of a healthcare crisis, I'm not my best advocate.
Right.
If I can go into the ED or go into a medical appointment armed with, here's my list of questions, here's what I know to be true, and then, like, not anticipating the barriers, but if I get them, like, I've had to fire clinicians off of my team.
Yeah, same.
Because we're not aligned on outcomes, on quality of life, on how I want to be cared for. So I think a lot of people also, that comes from a place of privilege, like, especially in the rare space, if you've got one clinician that is a specialist in your condition, you can't fire him.
No, you can't.
So how do you work with him or her? Sorry, that's a stereotype, but I don't know. It's like, I feel like there's give and take on both sides. To me, anytime I can root a conversation in, this is how long I've been experiencing it, I understand. I'll use a lived example. I have problems with my kidneys. I oftentimes will present, if I get a kidney infection, it goes from 0 to hero very quickly. You've been in the hospital with me as a caregiver for me in those instances. When I'm not listened to, so typical people, you get a kidney infection, you get some antibiotics, you go home, you're fine. When Kristy gets a kidney infection, oftentimes it ends up being an admission into the hospital.
Sure.
I've had a blood infection from, if things can go wrong, sometimes I'm that person. So I have to advocate loudly. I can't be on this antibiotic. I need this. I can't be sent home with these symptoms. I need this and this before I can go.
Mm-hmm.
That's hard because it goes against their typical protocol.
Right.
I don't know how we change that other than from med school to and I'm seeing it. I'm seeing some clinicians or some systems co-designing. At the root, when you co-design with someone, how you engage with patients and caregivers dictates the level of service that you're going to provide, in my opinion.
I think so much of it is, and this is where I sort of struggle a little bit when I look at these things, is I often wonder, you know me, I'm not very forgiving. I like to throw stones at glass houses. But I just think, at the end of the day, you are in the people business, and anyone who tells me anything different about a doctor or a nurse or anybody else, I'm sorry,
Yes.
you are helping people. And if you don't want to do that, be in a research, go be a researcher.
Yeah.
Go
If you don't like
somewhere.
people,
If you don't
don't
like
be on
people,
frontline medicine.
right. So, and this comes in to the second part of often why we get phone calls is we get phone calls sometimes where something didn't necessarily go catastrophically wrong. And that's a good thing, obviously.
Mm-hmm.
But we get a lot of things sometimes that are just like, you know what? I want to file a lawsuit because they didn't listen to me, because no one talked to me, because I was dismissed, because they were rude, because my mom was left waiting for a number of hours, because I wasn't given any answers, because on and on. And I think, no, those aren't cases. And those are going to be dismissed entirely in most instances are going to be dismissed entirely, because now someone's got to figure out how to call the patient ombudsman or how to find the hospital person to file that. You and I have had conversations about our friends who have been in those situations, right?
Yep.
Where do they escalate that to? Where do they go? And at the end of the day, there's no real consequence for those behaviors, right?
Right.
And then we can have all of the reasons as to why clinicians or doctors or nurses are burnt out. The healthcare system is overburdened. They're burnt out. They're this, they're that. And sometimes I come back to it and I say, that's not my problem. It is my problem, and that in the sense that that's why I work towards it. But I often think to myself, how much of this is just attitudinal? How much is that power imbalance? How much is it that someone goes in and says, you know what? I know what's right and you don't, or I'm tired, or this is my 50th hour in a row, or I didn't get any sleep last night, or right. So we have to fix that.
Yeah.
But that's also not my problem. So I need you to show up, take a deep breath, block it out, listen to the person in front of you, have some respect for what they're coming forward with you with. Don't dismiss them. Be respectful, be kind, be professional, and maybe practice a little bit of humility.
Humility and empathy, right?
Right.
Like,
I think that would make a huge difference.
Well, and I think where my brain immediately goes is this would require a huge cultural shift and change management.
Absolutely.
Protocol.
Right.
But if you think about businesses so I'm like deeply interested in customer experience and how that plays into our healthcare system.
Right.
Because like we're in Canada, our healthcare is paid for.
Yep.
Paid for.
Yeah. Well, yeah.
So I don't know that our systems give any consideration into what the customer experience is.
I'd say zero.
I think that's where, first of all, so that's the base level starting point of why we have a problem.
Yeah.
Because in any other world, like if you look at the KPIs that hospitals are driven by or working towards, you send out a patient survey. Where do those results go? Right. What actually changes from it? I'm going to say, this is where I will be a pessimist. Like, I think they go in my feedback. I give my kids a feedback box. It's called garbage. Like,
right.
Put it in the Wawa box and we'll move on.
Yeah.
But in any other industry, those insights are gold. That customer feedback is how you make operational improvements, you make efficiencies, you improve people's experiences so that they want to come back to you, or they need, if you're getting cancer treatment, are you going to go here or are you going to go here?
Mm-hmm.
The problem is they feel, in my opinion, the system is built in such a way that they know that they have us, so they just don't care.
Yeah.
And I say that on one hand, but I'm doing work with systems that really deeply do care.
Yeah.
And are starting to look at those metrics and make changes from them.
Yeah.
So it's one thing to look at the metrics. It's another thing. Like everyone's got a PFAC.
Yeah.
Everyone's got a patient and family advisory committee. And again, where do those suggestions go?
Yeah. Yeah.
Over here. Never actioned.
No.
So I think we are starting to see, at least I am in with my clients in the work, some of the work that I do, I am starting to see, if you're going to take my feedback, I want to know what you did with it.
The so what
And
factor. Yeah. The so
right.
what. Yeah.
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 So if I'm going to give you my time, because again, the other thing is I don't think anyone has any respect for a patient or a caregiver's time.
No, none.
In no world, like I'm still getting letters from specialists in the mail
Yeah.
that tell me when my appointment is.
Yeah.
I have a full life. I'm a complete human. I've got a job. My job, like I wish I had nothing to do but manage my disease. My
Mhm.
life would be so much easier.
Right.
When you send me a letter that says you will come in on this date and this time, it is immediately disrespectful to the fact that I am an equal partner in this transaction.
Right. Right. Where's the Calendly? Give me a Calendly.
Right. Or
Let
just
me think.
give me,
Give me
let me,
options. Right.
yeah, let me call you and
Give
make a
me
time that
right.
works for me.
Give me options.
In October, I got an email for an MRI. I got it on like a Thursday and it was going to be the next Tuesday.
Yeah.
Well, I was at a conference.
Right.
So I know this is like it's a bit of a, I can't, we've been conditioned so that we should be grateful for our care,
Right.
right?
Right.
I'm
Right.
grateful that I got an MRI
Yeah.
appointment
Yeah.
because in Canada we have to wait.
Right.
I couldn't
Why
make
should
it
I
work.
have to shift everything for that? Why should I have to?
Well, right. So when I called the office and there was no context, it was just like, Bing, you're going for an MRI. I
Yeah.
didn't know the ordering doctor. I didn't know what it was for. Like I had no context.
And if you say I can't make it,
So I called and I said, hi, I received this letter. Can you tell me the ordering physician, please? First of all, they're indignant to take my call.
Yeah.
Like I'm bothering you.
Yes.
You're going to be paid for me to come in and do this service. Like,
Right.
but I'm annoying you.
Yeah.
So I call and I say, can you tell me the ordering physician? I can't make it on Tuesday. She's like, well, what?
Yeah.
Like,
Sorry.
I'm sorry. I don't have 2 hours I'm physically out of the country.
Yeah.
Well, then you can't come until May of 2025. I said,
Oh.
okay, that's fine. And
Yeah.
she's like, pardon?
Yeah.
Shocked.
Yeah. Okay, fine. What am I supposed to do?
Right.
What am I supposed to do?
Because again, like, so this is where I go back to, like, from a base level, look at me as a human being.
Mhm.
Don't just look at me as a diagnosis.
Yeah.
I'm
Yeah.
not a transaction.
Yeah.
So where things fall apart, I think, is just from the get-go. You're right. You and I both go to work tired. We
Mhm.
have to communicate with people
Yeah.
and collaborate with people,
Yeah.
even when I don't want to be here. I'm not feeling well. I've been on my feet. I've got a million and one
I gotta go
things to
do it.
do. Yeah.
Yeah.
So I don't know, to get back to your very first question, like how do you do it? I look at what I try to do is look at that clinician and remember that they're human. I
But then
I
it's got to be the other way too.
I know, but I can't control that. I can only control, I know I'm giving you an eye tick right now. I can only control my response to the situation. And so I will get louder when I need to get louder.
Yeah.
I will get feistier when I need to get feistier, but I
Yeah.
start with a base level. I recognize that you're a human being, and I'm going to give you the benefit of the doubt that you are trying to do the best for my care.
And you did sort of hit the nail on the head too when we take a look at and you and I have talked about this. Like there's projects you work on and I'm like, they need a research study with dollars attached to it to tell us that maybe treating people better in an ER environment would turn out better patient outcomes. And I understand it's data driven. It's not lost on me, but again, grade 10 math, grade 10 science. That's just the basis of who I am. But then I do think, like you said, at the end of the day, what is the consequence?
Yeah.
So when I look, anytime I see an organization, so I think it's always money driven, but it's also risk management. Anytime I see a hospital or somebody do something to improve their outcomes, it's because they don't want to get sued, because they don't want, right? There's a risk management piece to it. Or if it's a not-for-profit, like if it's a children's, even in a hospital environment, they need to show how great they are because they want donors to continuously donate to them. So if they have people that are saying, oh my gosh, I had the best healthcare ever here, please put money in for an MRI machine, people are likely to do that versus this hospital is a dump. Nobody cares. Nobody's helping me. They're probably not going to do as well from a marketing perspective. But there isn't, like, where is the accountability? And I also think about things like, listen, if a hospital or a doctor make a mistake or a nurse makes a mistake, there are bajillions of dollars. And I say that, yes, bajillions with a J.
Okay.
With a J. There are bajillions of dollars available in insurance to pay for those. So, that's another thing too, right? Like, do I think that a doctor wants to make a mistake and have that on their head? I've run into physicians who have seen McLean after the fact. You can tell they're devastated knowing that this was a situation that could have been avoided. Yeah. And I think that obviously that does.
Because they're a human being.
Because they're a human being. But then I also come back to the root of it, which is, well, this didn't have to transpire like this, right? This didn't have to end up like this. But when you cut it all out, our settlement, that was paid out by an insurance organization. The doctors didn't. There was no consequence put on the physicians, right? They just, that it's errors happen, mistakes happen, we move forward, right?
Well, and so I think, obviously I'm sitting here not, I think I deeply respect your lived experience and the position that you're sitting and coming at this from.
Yeah.
I look, from my view, our entire system is built, I think, from a reactive state versus a proactive state.
Yeah, for sure.
And so if you're already sitting in reactive and then you make a mistake, you make an error, it's catastrophic.
Yeah.
The problem is it's like, my husband's a firefighter. If he makes a mistake and someone's house burns down, that's a lot bigger than if whoever made this mug made a mistake and it's got a crack in the bottom and it just leaks.
Of course.
So we're talking about like catastrophic mistakes that impact so many people's lives.
Yeah.
And to your point, I think because you and I are both very action oriented, like, do we need to do a 5-year study to know that, if you remove this barrier and you put in this code that enables this to happen quicker? Like, do we have to really sit for 5 years and gather evidence and collect data but health? So
do we have to? Yes. Should we have to? No.
Yes. So it is. And I think it's because they have no risk tolerance.
Right.
What they don't realize is that on this side, you're trying to protect yourself from everything. But what that is stopping is any system improvements, innovation, adoption of new ways of working.
Mm-hmm.
Like you can't, those are not congruent. They don't go together.
Right.
I don't, geez, this has been a depressing.
Well, it's not, it doesn't, it's not supposed to be depressed. It's just, it really gets me thinking and I would say that this is something that occupies my mind a lot in the role that I play, both personally as well as professionally. Like I talk to a lot of people who have, I talk to people who potentially have lawsuits because that's part of my role. But I also just talk to people who are impacted all the time by not having their voice heard, that are having these negative outcomes when they're in a healthcare environment or they're doing system navigation in the healthcare world. And I think a lot of it is unnecessary. And a lot of what, we talk about on this podcast is informative and information, and hopefully people listen to it and maybe it changes the way that they think about things. And maybe I think about that a lot. I do. I think about what, again, the number of calls that we get from people. And I want to just say to physicians sometimes, like, if you could just not be like that.
Yeah.
It would help things a lot. Like also, take out the medical error piece, talk about like trauma, talk about people don't want to go back. There are people who go into a healthcare situation that are treated so poorly that they don't want to go back there. And I remember even with McLean in the ER, and he obviously would be susceptible to pneumonia because he had compromised lungs when he was born. And so for the first 7 or 8 years, we were in the hospital all the time. And I had to advocate each time because, well, that's not how pneumonia typically presents. And so we would, I'd have to go in and do that.
Yeah.
And and I'd have to go in and, sort of advocate for that. And I'd go in and have to have, those conversations about like what was going on, and it would be so frustrating, but I would get through it. But then I'll tell you, did I second guess myself the second time I had to go back or the third time I had to go back? Yeah.
Yeah.
Would I sit there with a pulse oximeter on his finger? A lot of it's because I don't want to go, let's be honest. But why don't I want to go? I don't want to go because I don't want to have what happens when I get there. I don't want to feel embarrassed and humiliated to be there. I don't want to be questioned on my decision. I don't want to tell my story 55 times over. So I end up trusting my gut and I go, and I'm very rarely wrong. And in the times that, they make me feel like I'm wrong, I let them know that I'm not in fact wrong, because I'm very rarely wrong, just for anyone that's listening. I'm usually right. But, I go to that. But the point is that how many times are people not going?
A lot. Like there is actual evidence. There's a lot of evidence on like,
right. And where's that? And we don't capture that information. So when you let's think about you're somebody who goes in, who has an underlying heart condition, maybe it's AFib, maybe you happen to go to the hospital, you thought you had indigestion and you have AFib, and you get surgery 6 months later. I'm just talking from experience. But what if you go and you're dismissed and you're sent home? Okay. Sometimes we see people who go right back again, and then they're treated that time because they missed it the first time. So you're like, that's crappy that they missed it the first time, this misdiagnosis. But thankfully the person went back because they listened to their gut, or their caregiver took them back. Great. Yeah. What about the people who don't? So the person who doesn't go back and then they die at home, or something happens and they have a stroke, but here's the crazy thing is then it's harder to consequence that situation because the person didn't actually go to the hospital because they didn't want to go, because there was trauma from the first time they went. So we're not even probably capturing that secondary information, right? And I think about things like that. Like my point in all of that is that I remember having that conversation when McLean was having some significant GI issues. And by the time we made a decision to go, we went to our local hospital, because I'm not going to bog down sick kids if I don't have to go. We go to our local hospital, and the doctor who comes in, who's known us for a bunch of years, the pediatrician comes in the ER, and he's like, Brenda, why did you wait? And then I'm like, and I got visibly upset. He said, no, I'm sorry. That is not on you. That is not on you. But he said, I can't send him upstairs like this. The staff up there will kill me. They can't treat this situation. We're going to ambulance you down to sick kids. But he said, I didn't mean it like that. He said, but that's not like you. That's not like you. I've known you for a number of years. That's not like you. And I said, because over the past 6 years, we've been so dismissed with this GI issue. I said, I didn't want to come. I didn't want to come and have people tell me it was nothing, or dismiss it and go home and be frustrated. McLean gets poked and prodded and he gets through everything to have it be. So I said, I didn't. So by the time we got there, now it's an ambulance ride down. We're admitted ASAP and it's surgery the next morning. Right. And so then there's this layer of, I don't feel too guilty about things like that anymore. But then there's this layer of guilt, right? There's this layer. And then what if we hadn't have gone and it turned into something worse? Yep. But I think, because then the other part of that too is if you're a doctor working in a clinic, or working, your own clinic, or you're in a hospital, respectfully, it's not your business to tell someone that they can't come in, or they shouldn't have come in, or should people be in there for pink eye? No. Should they be in there because there's a hangnail? No. Yeah. But at the end of the day, that's not your job. That's not your job. That your job is to treat someone for what they've come in for, not to be schooled or to be, wrapped on the knuckles because you shouldn't have come in there. That's, I think, left to a different marketing campaign. That's left to a different conversation. But it's not up to the triage nurse or the person checking me in or the person that's coming in to check on the, the sty in my eye. Yeah. That's not your job. Your job is to say, Brenda, you've got a sty in your eye. Go home, soak a tea bag, put it on, and then follow up with your family doctor. Not like, why would you come in here and bog the system down and you shouldn't be here and there's nothing wrong with you? And because that is also what happens. And so should I have gone for a sty in my eye? No. Did I?
But do you have access to care otherwise? Well, I know I keep bringing it back, but like that to me is where these problems start, is like,
And people also, you know what, Kristy, like you said, you're not paying for this. And there is this mentality, like, I paid for it. I paid for it through my taxes. Yeah. I paid for this. And if I'm sitting there and this is causing me enough angst and enough upset, and to your point, I couldn't get in to see my family doctor, or I couldn't get in, and the average person doesn't always comprehend the concept of acute versus chronic when it comes
Yeah.
to whatever that is. So does it frustrate the crap out of me? Yes. There's nothing worse than being in an ER where you,
And like, I get it. I understand. And I probably feel some, well, I'm working right now on a project with really incredible ER physicians and nurses. So like I have had some good deep insights
Mhm.
into what it's like to sit in their shoes, because that's the other part of advocacy, right? Like, we know and we will advocate from our part
Yeah.
and where we come from. What I try to do is anticipate, like, okay, like, am I meeting you? Because at the end of the day, I just need my care.
Yeah.
So am I going to get there by being a bull and ramming through you? Maybe. Am I going to get there by crying and lying on the floor? And
Mhm.
maybe. Am I going to get, like, how am I going to get there? It's like a
Yeah.
choose your own adventure. So
Yeah.
to your point, I know for you, like, how am I going to get there? Because at the end of the day, we as us to know that we only go there if like, we are on death's door.
Yeah.
But that's not, so to your point, to the sty in your eye, there's an opportunity for different education
Yeah.
and to look at, like, truly, not in that moment, but like, why are they here?
Right. Is
Why
it
are they here and
misinformation? Is
not
it, yeah,
at a
for
walk-in
sure.
clinic? Or so that's when,
For sure.
like, you have to look at, that's not an advocate's job to explain to you.
Right.
Everyone is getting paid a lot of money to
Yeah.
build system navigation tools and to understand how the healthcare system works, and what you've got all the consultancies pointing out
Yeah.
as you're building your strategic plans. Here's your
Yeah.
gaps.
Yeah.
Do something about them.
Yeah. Yeah.
Don't pull it through year after year after year after year. We need, interoperability of healthcare systems. Well,
Yeah.
what does that mean? I just need you to talk to each other.
Yeah. Yeah.
We just need to speak to each other, or we just need, like, at the base level, it shouldn't be on patient and caregivers' backs
No.
to
To
thrive
no. To
when they're
no.
sick. When
No.
I'm well, I will help you all the
Yeah.
way through. But when I am sick enough to come to an ER or to make an appointment, because let's be honest, I don't like to see my doctors either.
Yeah.
I'm not going in just to chat with you.
No.
I'm taking time out of my day only if something is serious enough for me to need to
To
come
do
in and
that.
meet with you.
Yeah. For
And
sure.
that's your job, is to meet with me, to understand my concerns,
Yeah.
and for us to work together on what that plan's going to be.
Yeah. 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 It's true. And again, like, I mean, I know that this is a bigger conversation, and, I think I'm always looking for ways to improve this experience, this process, to make it easier for patients and caregivers to get access to the care that they need, to
Yeah,
navigate the system. I'm not quiet about the fact that I do think that sometimes, people who bring a lawsuit forward because they've been injured, maybe that's a mechanism for us to change guidelines and
absolutely.
protocols at the hospital. And sometimes that's a mechanism, and people can say whatever they want about it. But at the end of the day, sometimes it's the only way to hold someone accountable, because it is attached to possibly some sort of, consequence or whatever it is. But then there's also mechanisms, right?
But if you take it back to the retail example,
Yeah.
in the real world, if you treat me poorly, I'm not going to give you my business.
Right. Right.
And so in healthcare, if there's no, I'm not transferring in Canada. I'm not going in and paying you. I
No.
don't have choice.
No.
So then, unfortunately, oftentimes the only way to drive change is to be held accountable when
Right.
things go wrong.
Right. In various different ways.
And then what
Absolutely.
do you do
Yeah.
after that? So to your point, once the insurance pays out, have you changed a process?
Yeah.
Have you
Updated a
implemented
guideline. Yeah.
policies? Have you updated
Yep.
guidelines?
Yeah.
Like, are you doing things differently in your house
Yeah.
to make sure that this never happens again?
Absolutely. And that's, I think, what it comes down to. Are you doing the things, and what are we doing as a system to make sure that we cut those off at the pass? What are we doing to learn from our mistakes? What are we doing? How many times do we have to keep coming back to the table for the same conversations on the same things? And really, if you're doing a project in one area of the hospital, a lot of those things should hold true, right? Listening to patients, patient
Yes.
respect, all of the things we talked about aren't just, relegated to one area of the hospital. But again, we also know that a lot of this is driven by data. Sometimes you got to jump through the hoops. Sometimes you have to do these things because your funding body is asking for those things. But at the end of the day, what are we doing differently?
Yeah.
Regardless of the mechanism to hold people accountable, what are we doing differently? as a result of that consequence. But then, like I want to start to see things where we only see the numbers go up when it comes to birth injuries or it comes to medical malpractice cases. We see the number of them that come through us. We hear the same thing. If I take the legal part out of it, we aren't seeing patient outcomes necessarily improving the way that they should be in 2025. Right. We're just not. Given all the evidence and information that we know about the things we should be doing, we still don't see it happen consistently or effectively. And so I don't know. I don't know what that answer is going to be, because I feel like you and I have done a lot of work and we're only two people in this realm of patient advocacy, but there's a lot of us out there that are doing this. And yet I feel like we're still doing it all the time. So what is changing,
Yeah, so you're right. We are doing it all the time. And I don't know that we will ever be able to take our foot off the gas, because I think that's the actual work of advocacy. The minute that we solve one thing,
something else pops up.
You look and you're like, oh, well, we solved for this, but this ladders up into this, and we actually have to solve for this. So I think I put on a corporate hat oftentimes. I'm like, where's the root cause analysis? Are we not, to your point, why do we need a 10-year study to look at a root cause when we know
that it's a root cause?
Right.
It's an issue.
You literally know, if you listen to this person, or if you had a mechanism in place to not just solicit the feedback, but to action on it.
Yeah.
And then you take those actions and you measure them, and you make sure, and if they're not going according to plan, then you iterate on them.
Right.
But so for all, I think healthcare is not a business, but it actually is. It's a huge business.
Yeah.
And
so let's treat our patients like clients, and let's do better for them.
Yes,
and let's improve 100%. Those outcomes and
work collaboratively with the advocates.
Yeah.
We are not, you and I don't, very rarely do we advocate for ourselves.
Yeah.
You're advocating on behalf of a patient population.
Yeah.
A group
family
of people,
member, or a group of people, a diagnosis, whatever that might be. Yeah.
And you're advocating for broader change. I'm not advocating, I find it very, very difficult to advocate for myself.
Right.
I'm really good at advocating for other people.
Yeah.
When you advocate for large change and we see those tiny, small wins, then that propels the next generation of advocates, because let's be real, you and I are getting old and tired.
Well, I'm older than you, and I'm arguably more tired on most days, even though you go to the gym, but that provides energy. So I think it's different. Yeah, we are getting old. We're getting tired. We're getting old. And, at some point someone else has to take up the change. Right. And, what that's going to be, I think it's multi-pronged, and I think it's conversations, and I think it's just continuing to discuss it and
share best practices. Here's what I know this hospital system is doing.
Yeah.
Have you guys looked and thought about that? Here's what I know this manufacturer is doing, and how, I see it in the work that I do with pharmaceutical manufacturers are employing chief patient officers now.
I thought cheap patient officers?
Cheap. They're not cheap. They're in the C-suite.
I'd like to be a chief. If my boss is listening.
Yeah.
I would like to be a chief patient operator.
As would I. But that is an industry.
Yeah.
That is putting their money where their mouth is.
Yeah.
This is important
for the right reasons. For the right reasons.
We want to make things better.
For the right reasons.
We want to drive innovation. We want to drive change. And we recognize that you are an equal, respected, and valued stakeholder in this ecosystem.
Yeah.
And that is where I think if we could just get everybody on that to agree on that same playing field, we are equal. I didn't go to medical school for 8 years, but I deeply know this system in a way that you don't. And you monetize my feedback every day.
Yeah.
We are equal.
So next time, next time I'm on this podcast, I will be a chief patient
officer.
CPO.
I
I will be a CPO. Because I'm going to go look that up right now. I'm going to apply for that.
You should. I will name drop because they should be recognized. Roche just hired a Canadian in Canada, a chief patient officer.
Yeah, I love
and
that.
I celebrate that because that is a massive
I agree with you.
move
I agree.
forward.
Yeah, I totally agree. So on that note, then I've got some scrolling to do because I need to go
find a job.
And Kristy Dickinson Consulting, and I'm doing a shameless plug because you have built a platform and you have built a way to get this messaging out there in a more concrete way through the work that you're doing, through your consulting business. And, I think it's okay to take the stuff that we do for free sometimes and turn it into not for free because we work really hard at it. And I think we're bringing a level of expertise and a level of insight and experience that isn't there. And so I do think it's important that, patients and advocates are recognized accordingly for that.
Yeah. And the consulting work that I do increases your ROI.
Right.
Like it increases your revenue. It moves your deliverables forward. So that's a win for everybody.
Absolutely. So if you want to learn more about advocacy, patient advocacy, obviously you can listen to us because we'll do this again. And, but yeah, give you a follow.
For sure.
Take a look at your stuff. We'll talk again. Thanks, my friend.
Thank you so much for we have this conversation all the time, but platforms like this that share the why and a little bit of the how, because we know it's important. You inherently know, you see the data that comes across your desk. So we know what happens when things don't work well.
Right.
I don't think we talk enough about the good that happens when things do work well, because to your point, that's just someone leaving the hospital uninjured.
Yeah.
Well, how do you measure that?
Yeah.
We need to celebrate the really fantastic outcomes that happen and then do more of that.
Yeah.
It seems so simple, right? Like do less of what hurts and do more of what doesn't.
And if it does hurt, then you call me and I'll help you.
Yeah, there you go.
There you go.
Perfect way to end. Thank you.
Thank you, my friend. Thank you, everybody, for listening. Well, I guess watching now.
Yeah. Sorry they had to watch this for the last.
Well, you know what? The dog walked by and these things happen, but that's keeping it real. So thank you, everybody, for being with us. And we look forward to seeing you next time. And thank you, my friend.
Thank you. Have a great rest of the day.
Bye.